I was a little bit busy, so I couldn't keep tabs. Al fin, ¿quiénes estuvieron en la mañana?
Don't worry, just do your thing.
¿Cómo? Ah, sí. Todo bien. Yeah, Dr. Park was able to do this talk without a problem, and then Dr. Bilski.
What did Park talk about?
¿De qué era la de Park?
Don't worry. Time to catch up in person one day.
Oh, yes, we definitely do. Have to. I'll see if I can come visit as soon as I can.
Yeah.
It's kind of hard, but I really want to. Maybe I'll meet you one of your courses.
Yeah, December, please.
I'm gonna give that a try. It's kind of hard to travel right now, back home. So, listos? Okay, so we're gonna begin. Good morning to everyone and all the audience who follows our broadcast. Today at the IWBNC, we have the distinct honor of having Dr. Roger Hartle. Dr. Hartle is the Hanson McDonald Professor of Neurological Surgery, Director of Spinal Surgery and Neurotrauma at the Weill Cornell Brain and Spine Center. He's the Director of the Weill Cornell Medicine Center for Comprehensive Spine Care. Today, Dr. Hartle is going to share with us his lecture, Development of a Comprehensive Curriculum for Spinal Minimally Invasive Surgery. Please remember to type your questions in the Q&A section below. At the end of his lecture, we will read them out so Dr. Hartle can have the opportunity to answer the questions. Welcome, Dr. Hartle. We are honored and thank you for being with us, and the screen is all yours.
Well, thank you so much. It's fantastic to be back and with friends and with many participants from really all over the world. I'm very excited to talk to you about the development of a comprehensive curriculum for spinal MIS, which really has been a special challenge, but also a passion of mine for the last 3 or 4 years. And I want to share with you a little bit how we got there it's not totally finished now, obviously, but really how we got on our way to work on a curriculum that hopefully will have a big impact on how spine surgeons are being trained worldwide. First, I want to talk to you a little bit about MIS background. As you all know, minimally invasive spine surgery is increasingly penetrating the way that we are performing spinal surgery worldwide. It's a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function. At least that's the goal, and I think there are many procedures where we're already achieving that goal. The idea is obviously to minimize, and I'm going through this because I know that you've really covered over the last 2 days a broad spectrum of neurosurgery and spine surgery, and some of you may not be that familiar with minimally invasive, the ideas behind the minimally invasive surgery revolution in spine. So the idea is really to avoid injury to muscles, tendons, bones, to minimize iatrogenic injury to the spine, while still achieving the same surgical goal with the same, hopefully better outcomes and less side effects and complications. Now, MIS approaches really have been developed for all anatomical regions of the spine. And it is possible to treat most pathologies, at least partially, with less invasive or minimally invasive spinal approaches. And the idea, again, is to cause less tissue damage, less blood loss, lower infection rate, lower complication rates, get these patients up and going earlier, out of the hospital faster, back to work, and therefore have a big impact on society and health care delivery overall. Now, we came up with the 6 T's of minimally invasive spine surgery, basically to create like a framework that young surgeons and surgeons interested in MIS can kind of adhere to or try to at least explore to improve their ability to train and become good in spinal MIS. And the T's that we lined out was target, which is really patient selection. And that's, in my opinion, is probably the most important thing, especially when it comes to MIS surgery. Then tools and technology, that's what we all are familiar with from meetings, conferences, congresses, walking through the operating rooms. We have the microscope, we have fluoroscopy, navigation, and so forth. And then surgical techniques, and that's really one of the challenges for us to, especially to convey that to young surgeons. Obviously, we do that in our residency programs in the operating room, but beyond that, how can we really teach and train surgical techniques to young surgeons who may not have access to the operating room here, or who we want to treat remotely? Are there surgical simulation? Are there ways to use surgical simulation, for example, to teach and train those surgeons? And I want to talk a little bit about that. Teaching and training, obviously, is important. These webinars, online, again, surgical simulation, curriculum. What are the ways that we can teach and train young surgeons? Research, we're not going to talk about that a lot. And then talent. We think that really every surgeon has talent, obviously, and we should not assume that just because some surgeons may be more talented than others, that they wouldn't be able to do these procedures. And talent can be trained, as a matter of fact, but we're not going to talk about this a lot today. So what's the role of minimally invasive spinal surgery? This is really my favorite slide because it kind of illustrates the impact of MIS surgery. If you plot the complexity of spinal procedures against the invasiveness here, if you look at traditional open surgery, you'll see that increases very steeply, very quickly. Traditional open surgery is overall relatively invasive. The goal with minimally invasive surgery is to flatten this curve. If you look at the extremes of these curves, on the left side, very simple pathology such as a lumbar disc herniation, whether you do it open or minimally invasive, there's no real big difference. These patients go home the same day, complication rates are very low. And then again, if you look at the other extreme, which is complex deformity surgery, for example, it's very difficult to do with MIS, and the amount of invasiveness, if you do it MIS, is almost the same as you would do it with open traditional surgery. It's just not feasible at this point. And then there's in between is the sweet zone, the benefit zone, where MIS really makes a big difference. And I think that covers the pathologies of multi-level lumbar stenosis, for example. If you do an MIS stenosis decompression through a tube for 2 or 3 level lumbar stenosis case, there's a big difference between that and doing it open in terms of complication rates, post-operative pain, and so forth. MIS TLIF is really, I think, the poster child for MIS. That's really where MIS yields a lot of benefits. And then I think up to 2, 3, 4 level MIS fusion procedures for degenerative processes. I think that's where MIS currently is really very, very successful compared to open surgery. So that's the MIS benefit zone. If you look at this, you'll realize that in terms of numbers, there's a huge portion of spinal surgery that can be successfully covered with MIS procedures. But then there are obviously still, complex deformity cases where MIS is kind of challenging and so forth. So I estimate that about 75% of spinal surgeries can be done completely or partially using MIS. Let's talk a little bit about the different T's. Target. So how do you make a surgical decision? Well, the most important thing, especially for MIS, because we do a focal procedure, we have to have an accurate diagnosis. So we got to correlate the symptoms, the imaging, the patient's history, and then other tests, electrophysiological tests and so forth, to come up with a right diagnosis and then come up with the right surgical procedure for that. Now, the other thing you got to keep in mind is natural history of the disease. That will affect the way that you make your best surgical decision. And then the likely impact of your surgery on the disease process. And MIS is a great example here. if you have somebody with a grade 1 or grade 2 spondylolisthesis in the lumbar spine and you do an open decompression, the likely impact of this open operation is that you're going to create iatrogenic instability, and therefore you will have to do a fusion. However, if you treat this patient with a tubular or endoscopic decompression, you will not create iatrogenic instability, and frequently, therefore, you can avoid a fusion. So that's a great example of how the choice of your operation has an impact on the disease process, and therefore will also have an impact on your decision what type of surgical procedure to offer to this patient. Now, these are some thoughts about target patient selection as it pertains to minimally invasive spinal surgery. Let's talk a little bit about techniques. There are 3 technique principles of spinal MIS that come up over and over again. If you want to really understand benefits and the particular advantages of MIS, the idea that you can do a contralateral decompression through unilateral approach, the fact that by doing that you minimize iatrogenic instability, and then the use of interbody fusion for indirect decompression and deformity correction. Those are really the main principles of spinal MIS. And based on these principles, really, spinal MIS has become incredibly successful and will continue to become even more successful. So the idea to perform a unilateral approach for bilateral decompression through the endoscope or with tubes, the fact that this minimizes iatrogenic instability, and the fact that you use fusion procedures, minimally invasive for indirect decompression and deformity correction. So these are, in my opinion, the 3 most important principles of MIS. We talked about this. The idea that you can do a unilateral approach for bilateral decompression is not a new idea. This was really championed by some European surgeons, Spetzger and others in the 1990s, but it was really written up and popularized by John McCullough, who's an orthopedic surgeon, and Paul Young, who was a neurosurgeon, in this book in 1998, which is really one of my favorite books in medicine in general. They described with open surgery, but they described the fact that by doing a unilateral approach, you can actually reach over to the other side and get a beautiful bilateral decompression. And then it was Rick Fessler, Kevin Foley, Larry Koo, and others who really popularized the tubular retractors. That was also in the late 1990s for microdiscectomies. And then the first publication that I'm aware of that described tubular decompression for lumbar spinal stenosis, which includes the over-the-top decompression, so the unilateral approach for bilateral decompression, that was Sylvain Palmer out of California, who described this in, I think it was in 2002, so a few years later. Now, this is an example, a patient of mine from quite some time ago who had grade 1 spondylolisthesis with severe lumbar spinal stenosis. So this is a great example where you can use the power of minimally invasive surgery to avoid a fusion operation in this patient. So this is a patient who had essentially neurogenic claudication, no mechanical back pain, no instability on flexion extension films. And the question is, do you have to do a fusion in this patient? And if you do an open procedure like this, you probably will have to do a fusion because you remove a lot of the stabilizing elements of the spine. You take down part of the facet joint. You remove the interspinous ligaments. But if you do a tubular decompression in this patient, you do not have to do a fusion. So it's a great advantage for the patient. And I still have to find the patient who's going to, be happier with a fusion than without, or a patient who would opt for a fusion if they can avoid that. So this was done in this patient, a tubular approach, a unilateral approach for bilateral over-the-top decompression with a very nice radiographic or MRI, based result post-operatively. So we call that the ULBD, the Unilateral Laminotomy for bilateral decompression. And so this lumbar stenosis, you place a tubular retractor, you get your lateral X-ray to confirm positioning, and then you do, your unilateral over-the-top decompression. over the top, and so you get a beautiful bilateral decompression in this patient. But you got to practice, you got to train this. You can't just go to the operating room, drop a tube, and do this. This is it's a microsurgical, it's a complicated operation that takes some time to really learn. Once you know how to do it, obviously it's pretty easy. But how do you learn this if you don't have access to this technology? If the surgeons that you train with are not familiar with this operation, how do you do that? Well, that's what we're going to talk about. And now we expanded this to the cervical spine. This is a patient, an elderly patient who was not a candidate for decompression, open, and fusion, who had a myelopathy based primarily on this problem here at C4-5, severe stenosis. So we dropped the tube and did a tubular over-the-top decompression. We described this also recently in operative neurosurgery. And together with Dr. Soriano from Mexico City, we combined our cases and came up with a nice 10-step technique for this operation. And it's a great operation that I do now all the time in patients who are candidates. Obviously, again, patient selection here is the key. So, so if you know how to do decompression through a tube, frequently you can avoid fusion surgery. And these are some of the pathologies where we use this now routinely, and we can avoid having to do a fusion in these patients. Now, the other technique principle I talked about was interbody fusion for indirect decompression. You know, the lateral approaches that most of you are also familiar with, very, very powerful, minimally invasive, great surgery for selected patients who have a component of mechanical instability or deformity that requires a fusion operation. And in these patients, if selected properly, again, you can put in a cage, get beautiful indirect decompression. And this is less invasive because it addresses so many problems at the same time. And you don't have to go in from the back and do a direct decompression, which is always great because then you avoid potential morbidity to the patient because of spinal fluid leaks, nerve damage, and so forth. So the other obviously powerful aspect of doing lateral surgery or oblique lateral or anterior or ALIF surgery is the ability to correct the deformity. And with lateral surgery now, with the hyperlordotic cages, ALL release, and so forth, this has become a real benefit and really allows us to expand the indication for minimally invasive spinal surgery. This is reflected in the recent algorithm that was published. One of my partners, Kai Fu, is part of this group with Praveen Mumanemi, where they really looked at a large series of patients that were treated with open or with less invasive, minimally invasive surgery. And the ability now to use expandable cages, lateral approaches, ACRs, mini open PSOs, expandable cage technology, and so forth. So these are all things that came out of the world of minimally invasive spinal surgery. The fact that we can now incorporate those in our treatment algorithm or surgical strategies for deformity really expands the indication for minimally invasive deformity correction significantly. And this will continue to obviously be the case over the next years. And so the ability to treat also complex deformity problems with minimally invasive surgery will continue to expand. Now, this is an example of how we use now surgical simulation using a model that is made in by company that replicates lumbar spinal pathology. This is a course that we did a few years ago in Davos, an AO spine course, where we use a lumbar spinal stenosis model, and we train less experienced surgeons to use regular surgical tools such as the drill, all the micro instruments to perform a lumbar decompression procedure in the operating room. You can see here under the microscope, the model is made of plastic materials with 3D printing and so forth. You can see the dura, you can drill the bone, you use your Carasens. So this now, and I'm sure many of you who are listening here have probably had an opportunity to work with this model. And it's a beautiful way to really teach and train surgeons without having to go to the operating room It's more consistent than cadaver workshops for certain pathologies, and that has become very important for us in teaching and training a lot of surgical procedures, but especially the ULBD, the unilateral laminotomy for bilateral decompression through tubular retractor. And this is a really great operation to teach that way because it's always essentially, and we wrote it up, it's always the same procedure, always based on the same landmarks. So you dock your, and this is shown now at L4-5 on the right side in a drawing here, but you find the, in this case, the L4 lamina on the right side, and you remove part of the lamina here with the Carrison. You find the insertion of the ligamentum flavum under the L4 lamina, then you start removing the ligamentum flavum, and then you go contralateral by tilting the tubular retractor and the patient away from you. And so you can undercut now, you can look under the spinous process and you can undercut the contralateral lamina. You leave the contralateral ligamentum flavum intact, so the drill is not close to the dura, obviously. You protect the dura in addition with your suction that you hold in your left hand. So you got to be able to drill with one hand and hold the suction in the other. And that's a skill that's difficult to teach surgeons unless you can really show them how to do it in a model such as the real spine model that I showed you before, or in a cadaver. Those are things that where these surgical simulation technologies are really helpful. And then you do your over-the-top decompression. And this is a video from a case in the operating room. This is where we go contralateral. We separate the dura from the contralateral ligamentum flavum and the bone. And that's where surgeons get a little bit nervous because you're drilling very, very close to the dura. But if you do it the right way, you protect the dura with your suction here with your left hand, and you drill really the bone, and the ligamentum flavum here protects the dura from the drill. So you drill a trough, you drill a hole essentially on the other side of the ligamentum flavum, and that will protect the dura. And if you do that, then you can do this very, very safely. As you drill it, it's almost like skull-based surgery. You drill the bone behind the ligamentum flavum, decompress everything, and then you can get in there with your Carrison and remove the ligamentum flavum without having to put a lot of pressure on the dura and get a beautiful contralateral decompression. And now we go back to the ipsilateral side to complete the decompression on the ipsilateral side. So that's the surgical, the critical step in this over-the-top decompression procedure, and we wrote that up. The surgeons who really developed this, which was really Kevin Foley and Rick Fessler, they never really wrote this up. So we wrote it up based on our experience, and this became really a very, very successful paper and publication. So we put together all the little tips and tricks that we use in the operating room. How do you hold the drill? Where do you start drilling? What type of tubular retractor do you use? At which levels? What are the complications? How do you fix a CSF leak and so forth? So we wrote all that up, and it's been a great, really a journey then from there on, because then we started talking to the AO and we started talking about how can you standardize surgical procedures, again, to improve, to help surgeons to, I want to make sure I'm respectful of the time, but I think we're doing pretty well. So how can you standardize this operation? And the beauty of this operation, in my opinion, is that it's always the same operation, but how do you convey that to surgeons? How do you translate that into a curriculum or in a step-by-step way so surgeons can actually understand that and then also adopt that? And obviously, at the end of the day, everybody's going to do things their own way, but I think especially in the beginning, it is helpful to learn based on a step-by-step rigid procedure. And then obviously, as you become more experienced, you'll develop your own kind of nuances and your own variations. So in order to define these procedure metrics, we called it, in order to define those, we put a bunch of experienced spine surgeons together. So Andreas Korge in Munich, who's an orthopedic spine surgeon, who's a real expert in MIS, who, I've worked with for many years. And then obviously Kevin Foley, was a great pleasure and honor really to work with him on that. So we they all do this operation. So we asked them to formulate the steps, how they do it in their personal practice. And we try to come up with a combined version where we put together the steps for this operation that we all agreed upon. So we came up with these 10 steps here that are listed. We're not going to go through all those steps, but I want to walk you a little bit through the process of how we did this. So we had 3 experienced surgeons. We developed a consensus reference procedure for ULBD with phases, with steps, and errors. We also defined the potential errors that can happen. CSF leak, and you drill too much, you get through the pars, you cause instability, all these complications that can happen. And then we reviewed videos together. We reviewed the literature, obviously. And then we reached out. Once we had our document, we did a modified Delphi panel. We contacted 26 spine surgeons from 14 countries and shared our metrics and our procedure with them. And they gave comments. This is me watching Kevin Foley doing the ULBD procedure in our lab here in New York at one of our NICMIS courses a few years ago. And I can tell you it's fascinating to watch other surgeons to do an operation that I've done for many years, and I think I'm very good at. But to watch Andreas Korg and Kevin Foley do exactly the same operation, you always pick up little things that are just amazing. And so this was a great experience. And then after we had it run through the, so these are the steps and phases. So we identified 6 phases and 44 steps for this operation. It was meticulous, painstakingly meticulous. And we identified 21 potential errors, and some of them were more significant than others. So these are just some examples. I'm not going to go through all this, but for example, the errors are, to violate the facet, injury to the pars, insufficient ipsilateral decompression, a CSF leak, failure to avoid excessive pressure on the dura. And we did all this, I should say, using the real spine model that simulates lumbar spinal stenosis at L4-5. So these models are always the same, they're exactly the same. So we all did this operation with the real spine model, with the regular instruments that we would typically use in the operating room. And then we defined these phases and these errors. Now, and then we ran this through the Delphi panel. And based on the feedback from those 26 patients, some of the steps were deleted and 11 steps were modified. And then we came up with our final reference procedure. And this was published last year in the Global Spine Journal, and is available now online, of course. So where did we take this from there? So now we had our reference procedure. Well, who cares, right? Now you got 44 phases and 6 phases and 44 steps. Who cares? How can you put this into practice? Well, then we thought, well, maybe the next step would be to actually have surgeons, inexperienced and more experienced surgeons who want to learn this procedure, have them do this procedure based on these metrics on multiple real spine models and see how they progress over time. And that's something that we did a few years ago, and we're just now submitting it for publication. So we did this with one of my fellows, Caroline Melchior, who went back to Munich, who's an orthopedic surgeon. She's now in Ulm, but she did the study in Munich, and then we did it here in New York with 6 orthopedic and 5 neurosurgical residents. And we had them do the over-the-top decompression in a real spine model 3 times in a row on 3 consecutive days with briefing in between. So they did it one time, and we video recorded everything, and we had people watch it and take notes of mistakes and so forth. So everybody did the procedure 3 times. As you can see here, the overall improvement, was about 30%. The patients, the surgeons who were less experienced showed greater improvement, as you would expect. And we looked at things as the knowledge of instruments, instrument handling. respect for tissue, time and motion, and so forth. We looked at the number of errors that were done based on our metrics that we had defined. And, in the first procedure, there were 14 errors, second procedure, 8, and then in the third procedure, only 1. So there was a significant learning effect, as you can see here. The time for each procedure dropped significantly from the first to the third procedure. We did a gap analysis, and we also reviewed videos and had an independent. We had several surgeons look at the videos and grade the video performance here. And the improvement there, if you look at video grading scales, was also about 30% from the first to the third procedure. But essentially all surgeons improved, the inexperienced ones more than the experienced ones. So that was a great, I think it's one of the first times that you can actually show that by using a defined protocol, a step-by-step procedure, you can very, very quickly teach and train surgeons in a surgical simulation setting successfully, and then hopefully translate that obviously into patient care as well. So from there, then we in parallel, and then from there also we talked to the AO, and we're always interested in using this information and more to come up with a curriculum that we can use at courses worldwide, AO, but also outside the AO, hopefully, to teach and train surgeons interested in MIS. And we started in 2018 with the substantial help and really encouragement and support from the AO. We decided to put together a curriculum based on videos, PowerPoints, PDFs, and so forth to cover basic but also complex MIS procedures and competencies. And we put together a panel of 8 task force members. We wanted to put emphasis to have a group of international surgeons, to have a group of a mix of orthopedic and neurosurgical spine surgeons, but all of which obviously needed to have an interest and also expertise and experience in MIS. So we have Richard Asaka from France, Mohamed Assous from Jordan, Christoph Hofstetter from Seattle, Dr. Kim from South Korea, Avelino Parajan, Nestor from Colombia, and Paul Taylor from Australia. So we had multiple meetings, in-person, virtual meetings, and what came out of this was a comprehensive curriculum. I'll walk you through this in our remaining time that we have. So again, the goal is really to make this available for all surgeons worldwide, for this to be taught in spine courses, and to help train the new generation of expert MIS spine surgeons. Now, we decided not to just cover procedures, but also to talk about MIS skills, because in teaching MIS courses for years now worldwide, the experience that all of us got that the challenge is not always a procedure. The challenge is really the skill of performing the procedure and very specific skills. For example, a lot of surgeons are not familiar with a microscope. Either they don't have it or they never use it. They don't know how to use it. And it's not being taught in all spinal programs. So we put together some material that really addresses that problem. How can you understand the benefits of a microscope? How can you use it? Same with the endoscope. Increasingly important for MIS, surgeons need to know the basics of the endoscope. How do you use a burr with the endoscope? How do you use a burr under the microscope through tubular retractor? How do you hold the drill? How can you get to the point where you can drill with one hand and use suction in the other hand without causing a problem? So we cover that. How about imaging technologies, fluoroscopy, 2D navigation, 3D navigation? How can you incorporate that into your practice? What happens if you have a spinal fluid leak? How can you fix a spinal fluid leak through a tubular retractor? Everybody always wants to know that. Very, very difficult to teach and train unless you have surgical simulation and unless you really address that in a course. With a real spine model now, you can create a CSF leak and then you can fix it very, very effectively. It's a great way to do this. bleeding control. I do, I go to Tanzania a lot to do surgery, and I brought some tubes with me, and I tried to do over-the-top tubular decompression in Tanzania because I thought it would be an amazing thing. There's no infection. Patients, do so well. The problem was bleeding control because they don't have hemostatic agents. So an operation that's in New York, is totally straightforward. Was very, very difficult to do in Tanzania because they don't have, gel foam, flow seal, all of these things that we use for hemostasis. So something to really look into. And then radiation reduction. So we put together PowerPoints, videos, educational material, how to use a microscope, for example. This is like teaching how to hold a drill, like a pencil. You always brace it on the edge of the tube, and that allows you then, and then you put, I like to put my finger on the patient here for additional stabilization. Once you do that, you can drill with one hand and use the suction in your other hand. We covered initially 4 microscopic procedures. Those are all with a tube. So a unilateral approach for bilateral decompression for lumbar stenosis, a microdiscectomy, a far lateral microdiscectomy, and I think a posterior cervical tubular foraminotomy. And we created with the AO, and the AO did a terrific job with the illustrators and with their support staff and educational experts, really spearheaded this, and it's quite an amazing experience. We did here the PDF for over-the-top decompression. We covered, Luke Kim and Christoph Hofstetter really put together terrific material for endoscopic procedures. They also introduced a new nomenclature for these procedures that has been published separately. That also came out of this MIS task force work, which was a great achievement. These are some examples of some of the endoscopic teaching materials. There are videos, PDFs, PowerPoints, pre-recorded lectures, and so forth. And then we covered, in the first iteration of the task force, we covered percutaneous screw and rod placement, MIS TLIF, and that comprises PDFs. We also have on a touch screen, we have a software that you can download to look at it on your iPhone. We cover the step-by-step for percutaneous pedicle screw placement with fluoroscopy. And this is I forgot the name of the software, I'm sorry. And but it's on the website. And then we covered all types of procedures. Now, what we're currently working on now are working on microscopic tumor resection. So with through a tubular retractor, do a laminotomy, remove intradural pathology, tumors, and which is really a routine operation now, certainly for us here in New York. And it cuts down on the, obviously potential side effects, the cephalics and so forth, if you do it properly. And we're covering now ALIF, lumbar lateral surgery, OLIF surgery, and the combination single stage surgery, ALIF, lateral surgery, percutaneous screws. How do you put that all together? So that's all being covered now in the new upcoming iteration of the curriculum. And then we're also expanding some of the endoscopic, especially the posterior cervical endoscopic procedures. So this is all very exciting. Now the curriculum is available at the AO courses. There's limited access for non-members, but if you sign up for an AO course, then obviously you can harvest the benefit. I know that the AO group in South America, which may be of interest for the audience today, has done an amazing job in putting together educational material for minimally invasive spinal surgery. And we're in the process of working with them to really take advantage of this, because they're really way ahead of all the other groups in spinal education, especially when it comes to MIS. So kudos to them and great job. But that's it in terms of the curriculum. I think I'm at the end of my presentation. I will just summarize by giving you a few final points here. We talked about the 6 T's of MIS, which is the target, the technology, techniques, teaching, training, testing, and then talent. And the idea here is obviously to create a framework that young surgeons can use to really expand and really to become comfortable with MIS surgery, understand what they have to learn in order to really become successful MIS surgeons. So the surgical simulation with real spine, in my opinion, has been an amazing opportunity. For example, we just did a course with the AO in North America where, because of the COVID restrictions, instead of having everybody come to one location into a lab, where we actually had real spine models shipped to particular hospitals. And we did an online Zoom educational event where the fellows at the hospital in a conference room, you don't have to do this in the operating room necessarily. So they did an MIS TLIF procedure on the real spine model. We called in as experts. We did that with Mike Wang from Miami, with Christoph Hofstetter, and we were like the teaching faculty. And basically, we're teaching those surgeons over Zoom, and they were in their particular location in small groups with a real spine model, doing the decompression, tubular surgery. Obviously, this requires some equipment, and this was supported by diffuse synthes. But in the future, this would be a great way of really bringing the surgical teaching and training ability to the surgeons rather than having surgeons travel to a particular location. And then the MIS curriculum that I mentioned in my presentation now, I think that's something that can be used online with before a course, during a course, after a course. And I think it will really allow us to spread the basics of MIS, but also more advanced procedures to surgeons worldwide. So thank you for giving me the opportunity to talk about this. I think this is a very exciting topic, certainly to me, and I hope you found that interesting, and I'm looking forward to your questions or comments.
Roger, thank you very much. This has been a very interesting lecture, and I think of a very important, huge impact on the world of MIS surgery. I have a few questions from the audience. The first one is the following. What recommendations would you give for young surgeons that want to start working in MIS, but maybe haven't had training during their residency? And at the same time, what kind of different recommendations would you have for an already established spine surgeon that has not done MIS surgery, but wants to start to do MIS surgery?
Yeah, that's always a challenging problem. I think nowadays, especially now because of all the changes that we've gone through with COVID, there's much more opportunity now to do a lot of this stuff online, as you know. Courses like these, but then also what I talked about, the MIS curriculum. Part of this is available online. I would sign up for a course, certainly. I mean, the AO does a lot of MIS related courses. Most of these courses now are, even if they're done somewhere else, you can log in from far away, as people do for this course now. So I would log on to those courses. I would review the educational material available. And but however, though, if you're really serious about it, at the end of the day, nothing trumps a visit to a surgeon who is a physical visit to a surgeon who is good in MIS. And I think that's really the absolute key. And you got to, at the end of the day, you got to watch somebody do this, and then obviously do it yourself at some point. But I think the combination of our ability now to do these Zoom meetings, to log on to maybe an AO course or NAS course or any other course that focuses on, or a company-sponsored course that focuses on MIS, combined with a real visit to a real surgeon who does this, and then I think the real spine, the surgical simulation with cadavers and with real spine, those are the key components. And it's now so much, I mean, compared to just a few years ago, it's so much easier now to really do this. And I hope that, especially with the MIS curriculum, that we really, show this to people, that this is really now it's much more straightforward.
Thank you. The next question is in relation with the spinal models. Definitely, simulation is one of the key tools in preparing surgeons for any kind of new technique, even not only new techniques with respect of our time in the evolution of scientific principles, but a new technique for each surgeon as well. But unfortunately, in many parts of the world, there aren't the economical resources to have such an up-to-date model like a real spine. So what is your opinion about animal models? And what kind of animal model would you maybe recommend to maybe use as an initial substitute for this kind of training?
Yeah, that's a great question. I know that I was part of a course in South America where we used animal models. I think it was pigs to work on MIS, and that was a great course. I remember, that was a great course. I can't tell you exactly which animal would be the most suitable. I don't really know, because we haven't done this here in North America. But I know that in South America that there's some experience with that. I know that the AO used to do a course in Europe, complications course in live animals, and they were training anterior approaches, how to fix, if you run into a problem with vascular injury. That was one of the most successful AO courses ever. I'm not sure if that's still running, but that was done in Strasbourg every year. And that was an animal-based course, and many surgeons used to go there, and they had great. Unfortunately, I was never part of that. I never went to that course, but what I heard was an amazing course. So I think animal surgery is great. The real spine and is still too expensive. I think hopefully as the company grows and as they can become more cost effective, maybe this will hopefully translate into lower costs for surgeons. It has to, because it's still way too expensive. I totally agree. But if it gets to the point where it can be delivered, it can be done less expensively, then I think that would also be an option.
Thank you. The next question is with respect to endoscopic MIS spine surgery. So the question is the following: which would be the criteria to choose endoscopic procedures over MIS tubular procedures? And for those who want to start to learn or engage spinal endoscopic surgery, at what time do you think it would be prudent to start to do this shift?
Yeah, here I'm going to be totally honest. I looked at the list of participants. It's great to see all the people who are listening and watching, and I'm really humbled. But I'm going to be very honest. I'm not a good endoscopic surgeon. I tried it, and I just, for me, you have to. I think if I was 10, 15 years, I mean, not that I'm old or anything, but if I was at the if I was a young surgeon like you, or or even younger, like at the beginning, I would definitely pick up endoscopy, okay? Because it's like everything else, it's going to get better. I think right now it's still somewhat limited. I mean, you've got some real, master surgeons like Luke Kim and Christoph Hofstadter, and they dedicate a lot of time on this, and they become really good. But they become good because they do it a lot. It's the 10,000 hour rule. You got to spend 10,000 hours with endoscopy, like I did 10,000 hours with tubular surgery. So you got to start early. I think right now, if you're coming into MIS surgery at a later stage, I'm not sure that really picking up endoscopy is worth it, because you're going to spend so much time learning it. Mike Wang did it at a later stage, and he's become very good at it. But I think for the most part, I think you're better off. I think tubular surgery is a little bit more intuitive if you're starting later in MIS. But if I was a young surgeon, I would definitely pick up endoscopy. All
right, thank you. The next question is with respect to surgeon training. So I know in the MIS AO curriculum, there's a quite comprehensive list of how you should board or start to study MIS surgery. But sometimes it's always easier when you hear it from the experts. So the question is the following. ULBD is the foundation with pedicle screws for initiating spinal surgery in MIS techniques. What would be the natural progression, do you think, that would be recommendable for a surgeon that's starting to MIS and is going on more and more complex surgeries? What kind of surgeries would that be? What order should be recommended to gain in complexity? That's the first question. And the second question, which is closely related, is, do you think that, for example, in the MIS TLIF case, do you think that a resident or a surgeon should first be proficient in open TLIFs, for example, and then MIS TLIFs both at the same time, or MIS TLIF on the get-go?
Right. Yeah, I mean, the progression is, see, they're different kind of, they're parallel pathways. I wouldn't say that, you got to start with 1, 2, 3, 4. I mean, when it comes to tubular surgery, certainly the progression is, you do a microdiscectomy first through tube, then you do an MIS laminectomy, and then you go to the MIS TLIF. I mean, that would be like the progression for tubular surgery. Then there's endoscopy, and I don't think you have to do tubular first and then go to endoscopy. I think they're totally separate pathways. But I think you have to make a decision. I think it's going to be very hard for surgeons to be equally good in tubular and in endoscopy surgery. So I think that, like I said before, if I was a young surgeon, I would probably certainly look at endoscopy very seriously, and then that's a different pathway, And then there's lateral surgery, which has nothing to do with tubular surgery really, or not that much, because there are different complications, different risks scenarios. So that's also that's also a parallel pathway. I don't think you have to do a tubular laminectomy first before you do a lateral fusion. It's totally different operations. So you got to think about it more in a parallel fashion rather than in a sequential fashion. For tubular, though, as I mentioned, it's a microdiscectomy, then the tubular laminectomy for stenosis and the MIS TLIF. But in parallel, I think you should then also look at lateral surgery, and you can certainly do that. There's no reason why you shouldn't be able to do that. But you have to do certain things in parallel. You can't just, it's not like totally sequential. I hope that makes sense,
Thank you. We have a question from Dr. Onyibe in Nigeria, and he wants to ask you what would be the way to, or how could he contact to get into the program over in Tanzania to share some experience with you?
Yeah, the best way is, and I showed my email before, send me an email and just and the best thing is to send me an email and Google neurosurgery Tanzania Weill Cornell. If you Google that, you find all the contact, and certainly would love to have him and others involved in all of these projects.
Great, thank you. So that would be the questions for the time being. I'd like to thank you again for being with us in this second iteration of the IWBNC. It has always been a great pleasure and an honor to have you with us. And thank you.
Great, thank you so much. You put together a great program, and it was a pleasure being here. All the best to you and your family.
Thank you.